One day in September 2008, Tom had a fit when he, his wife, and young son were staying at the house of a friend. Narrating the story in her book titled The Iceberg, his wife, Marion Coutts, said, "We don't know why." He never had one before, and the shock took us straight into hospital in the night. Whilst they were unnerved by the event, he recovered well and was discharged home after a brain scan. He subsequently received a phone call to tell him the scan had revealed a brain tumor, which was very likely malignant, news that his wife referred to as a conflagration and as a fireball. As his tumor was in the area of the brain that controls speech, he also had language difficulties, struggling with pronunciation and even simple words. 2 years later, in addition to fits and minor speech problems, he had started manifesting changes in his personality and intellect. His wife referred to these as the obliteration of a person, his intellect, his experience, and his agency. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast. In this episode, we will be exploring the scary subject of brain tumors. A seizure is a frequent presenting symptom of brain tumors, as was the case with Tom. A seizure also heralded Jessica Norris's brain tumor, as she chronicled in her illness memoir titled All in My Head. Whilst out hiking with friends, she suddenly experienced overwhelming fatigue, impaired speech, and then loss of consciousness. This was associated with a seizure. Curiously, a month before this, she had experienced an unexplained fall, and this was associated with a transient feeling of what she said was one side of my body being slightly pulled down. In retrospect, she thinks this was the first seizure she had. And although seizures are more likely to manifest with low-grade brain tumors, there is a wide variety of tumors that are likely to present with seizures. And indeed, Morris turned out to have the most aggressive form of brain cancer, a 3 mm glioblastoma multiforme, which she referred to as the worst of all 120 plus different forms of brain tumor. Incidentally, Tom also had a glioblastoma multiforme. Another illustrative example of brain tumor first presenting with a seizure is that of 29-year-old physician Courtney Burnett, which she narrated in her memoir titled Difficult Gifts. Burnett was just finishing her residency training, and she was on rotation in Thailand when she said she started to experience strange neurological symptoms. The first of these was a sudden intense sensation of cramping in her left hand, and this lasted about 20 seconds, followed by a strange sensation of dysphagia as her throat went into a spasm, and then she drooled from the left side of her mouth. This symptom recurred 2 days later, and she recognized that these episodes were seizures. Her first MRI scan of the brain revealed a large brain tumor, which she said took away every hope and dream I had ever had for myself. She was initially treated with steroids and anti-seizure medications, and these were followed by brain surgery. The biopsy of the brain tumor indicated that she had a low-grade glioma, and her neurosurgeon told her that this may only require surgery and no other aggressive therapies. She said, "I started thinking of a low-grade glioma as an evil, scheming neighbor who steals my Amazon Prime packages but isn't quite smart enough to figure out my full social security number." Sadly, it later turned out that the tumor was actually a grade 3 glioma called an astrocytoma, which required more than just surgery to treat the 5% of the tumor that could not be removed at operation. But an MRI plan before radiotherapy and chemotherapy showed that the tumor was growing faster than expected for a grade 3 glioma. Another common presentation of brain tumors is with a headache, a worrying symptom which, just like seizures, is most frequently caused by non-tumor causes, but brain tumors are always in the consideration. An illustrative case of a brain tumor manifesting with headache was narrated by Jo Barlow in her memoir titled "It's All in My Head." Her problem started when she was painting her ceiling and she experienced neck pain, followed shortly by a constant dull headache. Her headache, however, was associated with some worrying features which suggested that she possibly had a potentially fatal increase in her intracranial pressure. One such red flag was the exacerbation of her neck pain and headache by coughing, sneezing, and straining. Another one was blurred vision, which forced her to keep blinking or squinting to clear the vision. And the third was vomiting. Her other symptoms were bobbing of her vision when she walked, difficulty walking straight, dizziness, and feeling drunk, like I cannot quite get my balance and coordinate the moving steps. All these suggested that there was a sinister pathology in her brain, and most likely in the cerebellum, the part of the brain which has very little space to accommodate a space-occupying lesion and which presents with most of her symptoms. And indeed, Barlow was eventually diagnosed with a 3 mm hemangioblastoma, a blood vessel tumor in the cerebellum, which is benign in pathology but malignant in location and complication. Beyond the headache red flags we have so far seen, there are other suggestive headache associations such as worsening of pre-existing headaches, headaches that are worse in the morning or worsened by neck bending and flexing, and headaches at the junction of the head and the neck. And perhaps the most important red flag sign on examination is swelling of the optic nerve head on ophthalmoscopy, a sign called papilledema. A person whose brain tumor was heralded by a headache without any relevant red flags was Nathalie Jacob. Narrating her story in the illness memoir titled 8, Rediscovering Life After a Brain Tumor, Jacob experienced an intense and persistent headache that required her to have a brain CT scan. The scan showed that she had a mass or tumor in the ventricle, which turned out to be an intraventricular meningioma. Meningioma, a usually benign tumor of the covering of the brain called the meninges, can, however, occasionally become malignant and, as in Nathalie Jacob's case, can occur in all sorts of places, including inside the ventricles. Particularly challenging for neurologists is when brain tumors present with non-specific symptoms and no brain tumor red flags at all. This was the case, for example, with Leanne Tripp, who narrated her story in the book titled Finding the Rainbow. Her illness started toward the end of her second pregnancy when she said she noticed a strange, yet can't put my finger on it change. And this was in her vision, requiring her to squint when texting. This was then followed by the experience of what she said was a tingling feeling that would run down the side of my left face as if water was trickling down the inside of her skull. After she gave birth, she continued to squint because of blurred vision, and she said walking felt more like stumbling, with images overlapping one another like a kaleidoscope of moving pictures, buildings over sky, sidewalks over grass. She eventually developed double vision and consulted a neurologist who arranged an MRI brain scan. This unfortunately revealed what appeared to be a glioma in her brainstem. She had a biopsy of the tumor, which turned out to be a diffuse pontine glioma, but with a slow growth rate of less than 1%. This information, she said, helped to craft an exactly right radiation plan. In describing her radiotherapy, she said, "The first order of business was molding a plastic cage that was an exact replica of my face. This would be clamped over me during the treatments. This was to keep my head still so that the radiation would be delivered with pinpoint precision." She had 36 days of treatment during which the mask was bolted to the table. She described how the linear accelerator that beamed the radiation rotated around her, delivering invisible medicine to stop and shrink the growth of my tumor. The side effects she experienced were fatigue and reversible hair loss. Thankfully, an MRI after the treatment showed significant tumor regression. The tumor remained stable after years of 6-monthly MRI monitoring, and she was declared in remission. We have so far come across a range of types of brain tumors, and Jessica Norris has already indicated that there are more than 120 different types. The major category in the classification of brain tumors are the gliomas, which include astrocytomas, oligodendrogliomas, and glioblastomas. And each of these has subclassifications depending on the features seen on pathological examination. Other tumor types depend on the type of brain cell they arise from. For example, meningiomas from the meninges, ependymomas from ependymal cells, and medulloblastomas from medulloblast cells. But irrespective of the type, the manifestation of brain tumors often depend on which part of the brain they arise from. The disheartening dimension of brain tumors is their tendency not to spare any age group. This depressing feature was well documented by Rob Delaney in his memoir of his son's brain tumor titled A Heart That Works. He wrote that his son Henry had just turned 1 year 2 weeks before he was diagnosed with a brain tumor. Henry's presenting symptom was recurrent and progressively worsening vomiting, and this eventually resulted in Henry losing weight. Delaney wrote that every time he vomited, I would freak out and I would start crying. The pediatrician they consulted requested a brain MRI scan because the vomiting was effortless, which may therefore be caused by lesions pressing on the brain's emetic or vomiting center. Sadly, Delaney wrote, the MRI confirmed that Henry had a large brain tumor in the back of the head, near his brainstem. This, he said, caused him the heaviest pain in the world. He remarked that it was excruciating to learn that something other than his brain was taking up a lot of space inside his skull. A neurosurgeon explained that the tumor was the size of an apple right next to Henry's brainstem and probably wrapped around important cranial nerves. A tinge of regret shadowed the narrative as Henry spent the next 14 months in surgery, recovery, physical therapy, and chemo, while his peers were learning to walk and babble and play around and splash pads at the park. Henry had a shunt inserted to relieve the pressure on his brain and later had major surgery to remove the tumor via an incision in the shape of a big 7 at the bottom of the back of his skull. Delaney said the neurosurgeons did their best to remove the tumor by first debulking the large tumor and then scraping remaining bits off the brainstem and cranial nerves. The tumor, hard and dense and had been growing a long time, turned out to be a grade 3 ependymoma. Henry had chemotherapy, which unfortunately made him sick and exhausted. After the surgery, Delaney wrote that it often felt like we were falling down a flight of stairs in slow motion with each successive piece of bad news we got. First, he said Henry lost the ability to swallow, to breathe, and to cry, and then he became susceptible to infections. Furthermore, he was deaf in one ear and hard of hearing on the other. He also had facial weakness on one side, and then he required a tracheostomy. Unfortunately, a follow-up MRI showed that the tumor had recurred. Finally, brain tumors can be secondary, coming from outside the nervous system, rather than primary as we have seen so far. A gripping narrative that portrayed secondary tumors or metastasis is that of Barbara Lipska, narrated in her memoir titled The Neuroscientist Who Lost Her Mind. Lipska's first symptom developed when she was out on her routine morning jog and suddenly couldn't recognize her familiar neighborhood, and she struggled to find her way back home. She subsequently had an episode whilst driving when she was unable to see her right hand, and this symptom was what led her to seek medical help. Her first MRI revealed that she had 3 tumors in her brain and 1 was bleeding. Although she has had breast cancer previously, these tumors turned out to be metastatic melanoma, a diagnosis that she pointed out was almost invariably terminal, with an expected survival of just 4 to 7 months. Furthermore, she wrote that all the poor prognostic factors for malignant melanoma were acting against her survival, and these are the large number of tumors and her age being over 60. Lipska first had surgery for the bleeding tumor, followed by several sessions of stereotactic or guided radiotherapy. Chemotherapy is unfortunately ineffective for melanomas. But very early on, she latched onto the idea of having immunotherapy, and she got herself included in an immunotherapy trial. Immunotherapy, however, triggered psychiatric symptoms, what she said was the eruption of a full-scale war deep inside her brain, saying that my brain is like a horse galloping dangerously after the rider has lost the reins. She developed altered personality, disinhibition, paranoia, and she became more and more uncaring about what other people think. Her subsequent MRI brain scan unfortunately showed even more tumors, 18 in all, what she said made her brain appear like a lump of resin-bred dough. A clear sign of failure of the immunotherapy. And yet she persevered and had cyberknife radiosurgery to good effect, followed by combination immunotherapy with dabrafenib and trametinib. These kept the tumors largely at bay, the occasional ones responding to radiotherapy. Why do brain tumors develop? In many cases, as with Tom and many other people, no cause is identified. In others, however, there may be one of many potential brain tumor risk factors. For example, there are genetic factors such as tuberous sclerosis and neurofibromatosis. There are environmental factors such as smoking, alcohol, radiation, dyes, solvents, and pesticides, as well as infections such as toxoplasmosis and measles. After his diagnosis with glioblastoma multiforme, the most aggressive of brain tumors, Tom went through a roller coaster of treatments which his wife Marion Coutts chronicled. Referring to the barrage of medications he was put on, she said, "We have never had need of drugs. Now we have the steroid dexamethasone, the anticonvulsant Epilim, and the chemo drug temozolomide. All are taken at home. The drugs are of such urgency and moment, they capsize us." As the number of medications he took to control his symptoms expanded, she said, "I have lost track of the drugs. Epilim, dexamethasone, omeprazole, metformin, clobazam, furosemide, alendronic acid." On the positive side, Epilim and clobazam helped to control his seizures, but the anti-inflammatory steroid dexamethasone, although it helped to reduce the swelling around his brain, however, led to significant side effects. She said over time it turned on his body and wore it down. For example, it triggered diabetes, for which he was put on the metformin, gastric irritation, for which he was put on the omeprazole, and it softened his bones, for which he was put on alendronic acid. More significantly, all the treatments that Tom had so far were all symptomatic, as they did not address the primary problem he had, the brain tumor itself. For these, the triple-pronged approach revolves around surgery, chemotherapy, and radiotherapy, as we have already seen. The first surgeon to successfully operate on the brain for a brain tumor was William McEwan, who in 1879 removed what was possibly a benign meningioma. This was on a 14-year-old girl called Barbara Wilson, and it was at the Royal Glasgow Infirmary. In his biography titled Sir William McEwan, A.K. Bowman wrote that the operation revealed a flattened fungus-like tumor of the dura mater, and this was connected to the periosteum, or the covering of the skull, where she had previously had a tumor removed. Bowman, however, pointed out that the great American neurosurgeon Harvey Cushing argued that this was not a true neoplastic brain tumor. Shortly after McEwan's attempts, Francesco Durante in Rome also removed a possible benign meningioma in 1884. In his biography titled Victor Horsley, Michael Aminoff deplored the fact that both McEwan and Durant performed their operations without reliance on studies of cortical function. And as we can see, there have been doubts as to what the lesions were. This is why Aminoff preferred to give pioneering credit to Rickman Godley, who carried out a tumor operation which he said was the first time a brain tumor was localized correctly and removed successfully by operation. Rickman Godley had operated on a 25-year-old farmer with epilepsy and progressive left-sided paralysis. In his book titled A History of the Brain, Andrew Pickens noted that physician Alexander Hughes Bennett had suspected that the farmer had a right motor cortex tumor. Notwithstanding this, it was to Victor Horsley that Pickens gave the ultimate pioneering brain tumor accolade. Pickens had argued that Horsley was the person who did the most to establish neurosurgery as a medical specialty. Michael Aminoff also portrayed Horsley as the first surgeon to devote most of his time to the nervous system, asserting that before him, neurosurgery as a field was largely unexplored. With specific regard to brain tumors, Aminoff narrated Horsley's successful brain tumor operation in London in 1886, and this was witnessed by the leading neurologist Hewlings Jackson and David Ferrier. Horsley, Aminoff maintained, was the first surgeon to base his brain tumor operation on principles derived from localization experiments in animals. Aminoff also posited that it was Horsley's series of brain tumor cases that demonstrated that brain surgery was feasible and safe. At the time of Horsley, neither radiotherapy or chemotherapy were existent. Since then, however, radiotherapy has become a central pillar in the treatment of brain tumors. The linchpins of conventional or standard chemotherapy are the alkylating agents, the most important being temozolomide, as seen in Tom's case. His tumor continued to grow, however, and he was then tried on a new chemotherapy agent called Avastin or bevacizumab. This is an anti-VEGF monoclonal antibody indicated for the treatment of recurrent brain tumors. This was, however, to no avail as Tom continued to deteriorate. Coutts wrote that after 10 days, we know that the tumor is advancing. Avastin is not working, things are shifting, tuning, widening. Each stage is marked and definable, yet without a clear edge to guide us. There's nothing at all to grab hold of. There are also a variety of treatments that are currently experimental. One promising area is immunotherapy, as we have seen with secondary tumors in the case of Barbara Lipska. Jessica Norris also had a form of immunotherapy in the form of nivolumab. Other drugs in this group include ipilimumab, pembrolizumab, bortezomib, CAR T-cell therapy, and human cytomegalovirus or HCMV-based immunotherapy. Norris was also on Optune, an experimental therapy that she said works by creating electrical fields that slow and stop cancer cells from dividing. She also had injection of herpes vaccine into her brain tumor as part of a clinical trial, having just failed to get on a similar trial using the poliovirus vaccine. To further the cause of science, Norris also donated her brain for cancer research after her sad demise. Unfortunately, the prognosis for Tom was also poor, as demonstrated by his progression. He eventually required hospital admission when his mobility worsened and palliative care in a hospice. It is, however, reassuring that the number of investigational brain tumor treatments is expanding rapidly, as we have seen, and this gives hope for those facing this dreadful cancer. In the next episode of this podcast, I will be speaking to Christine Miskelly about her experience of her husband's brain cancer, as she narrated in her book titled An Elephant in the Brain. Thank you so much for listening to or watching this podcast in which we started an exploration of brain tumors. If you found this podcast helpful, you might want to like or subscribe to the YouTube, Spotify, or Apple podcast. If you want to explore brain tumors more, you might consider my book Surfing the Brain for a layman's view on brain tumors, or for the more academic dimension, you might want to check my online neurology database called Neurochecklist. In the meantime, thank you very much for your time, and do join me in the next podcast when I'll be speaking to Christine Miskelly. Thank you very much.